This is episode 81 of the Psychcast by MD Edge, where we bring you interviews with leaders in the field, masterclass lectures, and relevant inspiration, straight to your ears with new episodes dropping on Wednesdays. I'm the voice of MD Edge podcast, Nick Andrews. Coming up later, Dr. Karl Doghramji gives a masterclass on insomnia. But before we get going, a quick word about what's coming up on Psychcast. This fall, we're going to have episodes about postpartum psychosis, neuroimaging and forensic psychiatry, and we're going to bring back MD Edge Psychiatry board member Dr. Dinah Miller to talk about involuntary treatment. Dr. Norris and I will be at the 2019 annual meeting for the Group of the Advancement of Psychiatry, known as GAP, in White Plains, New York. That's coming up this fall. If you'll be at GAP, come say hi. We're going to be chatting with leaders in the field once again this year, so if you have any topic ideas or requests for us at GAP, please send us an email at podcast@mdedge.com. And remember, we appreciate ratings and reviews on Apple Podcasts or wherever you listen. And if you're enjoying the Psychcast, please recommend the show to a colleague, friend, student, or trainee whenever you have the chance. Okay, it's time now for This Week in Psychiatry. Our story this week, virtual dark therapy using blue light spectrum blocking glasses turns out to be a highly effective adjunct to standard anti-manic medications in patients with bipolar mania. This is according to a study presented at the 2019 Annual Congress of the European College of Neuropsychopharmacology in Copenhagen. Dr. Tone Henriksen is a researcher and psychiatrist at the University of Bergen in Norway. She pointed out in her presentation that the virtual dark therapy is also a lot easier on the patient than the massive sensory deprivation that is imposed by the original form of dark therapy, which entails keeping a patient with mania in a completely dark room for 14 hours per night. In the study, researchers evaluated 23 patients with bipolar disorder who were hospitalized for manic symptoms. All of the patients in the study remained on their standard background psychiatric medications while being randomly assigned to wear orange-tinted glasses, which followed passage of almost no light, or to wear clear glasses. Participants were instructed to wear their glasses from 6 p.m. to 8 a.m. the following morning for 7 consecutive nights. They took off their glasses when they switched the lights at bedtime, but they had to put the glasses back on if they turned the lights on before 8 a.m. Patients also wore an activity monitor. The group who wore the blue light blocking glasses had an average of a 14.1 drop in their Young Mania Rating Scale from a baseline of about 25. This is compared to a 1.7 average drop in patients in the control group. Dr. Henriksen said that this result might actually underrepresent the true clinical effect of blocking blue light to the brain, since 2 patients in the study group experienced such rapid symptomatic improvement that they were moved from an acute psychiatric ward to a local hospital mid-study. This sudden change triggered transient worsening of manic symptoms in both patients. The investigators also documented improved sleep efficiency in the blue blocking group. Another noteworthy finding was that in the group who wore the glasses, the elements of the Young Mania Rating Scale related to increased activation declined before the measures of distorted thoughts and perceptions. So did motor activity as recorded by actigraph. Meanwhile, nighttime activity worsened in the control group. Those patients received substantially more sedatives, hypnotics, anxiolytic agents, and antipsychotic medications. And that's it for This Week in Psychiatry. Remember, you can stay up to date with the latest information in psychiatry by visiting www.mdedge.com/psychiatry. Okay, let's get to our masterclass lecture on insomnia with Dr. Karl Doghramji.
My name is Karl Doghramji, MD. I'm a professor of psychiatry with secondary appointments in neurology and medicine at Thomas Jefferson University in Philadelphia. I also direct the Sleep Disorders Center at that institution. Today I'll be speaking about insomnia, and I'd like to focus on some of the diagnostic criteria for insomnia. I'd also like to talk a little bit about the impairments associated with insomnia, which we're beginning to learn much, much more about. And I'd like to discuss a rational, evidence-based approach to address insomnia in clinical settings. First of all, from a DSM-5 diagnostic standpoint, insomnia is defined as a dissatisfaction with sleep quantity or quality, which occurs in conjunction with difficulty falling asleep and staying asleep, or both, and the symptoms need to exist at least 3 times per week and exist for more than 3 months, and importantly, need to cause some degree of dysfunction or distress to the patient. Important to remember that in DSM-5's nosology, insomnia can exist in this fashion as a disorder in conjunction with other disorders, and we no longer have to define what's primary and secondary. So it can exist in conjunction with other disorders without any notion as to whether it's primary or secondary, which is an important nosologic distinction from DSM-4. Insomnia is very common. We know that about 20 to 30% of the population has insomnia on a regular basis, and it's also more common in the psychiatric population. Inpatient settings, for example, are hallmarked by insomnia. This rates is up to 80% on a continuous level. There are many, many different causes of insomnia. Ultimately, insomnia is based on a notion of hyperarousal, central nervous system hyperarousal, or heightened reactivity. What causes that in turn, we're not sure. It may be high levels of anxiety, high levels of distress, but it does seem as though insomnia can be or does exist in the context of genetic vulnerability. People who have insomnia have a higher rate of insomnia in first-degree relatives. Insomnia also is associated with significant impairments. So, for example, insomniacs have a diminished ability to enjoy life. Interpersonal relationships begin to suffer. They become sleepy during the course of the day. Many of them do fall asleep inappropriately, such as when driving or in occupational settings. Interestingly, insomnia confers a greater risk for the development of various psychiatric syndromes, including major depression, post-traumatic stress, and drug use. Interestingly also, insomnia produces a greater risk of diabetes and hypertension development in the future, even if one does not have it currently. So this insomnia symptom, which we used to think as being something innocuous or maybe only annoying, seems to confer a huge risk for both psychiatric and medical comorbidities in the future. From a neuropsychiatric standpoint, insomniacs have impairments in cognition and memory, so that they tend to have less ability to remember important details about themselves. Episodic memory suffers. They also seem to have a diminished ability of working memory. That is, given complex tasks, they have difficulty knowing how to negotiate those tasks. Things like computers and job-related tasks in complex settings. Now, insomnia in order for us to evaluate insomnia properly, it's important for us to first of all understand the dimensions of insomnia or sleep for that particular night. So, does the patient have difficulty falling asleep or staying asleep? If it's a problem falling asleep only, that has a certain level, certain implications in terms of diagnosis and also treatment, as opposed to staying asleep or waking up multiple times. People who have difficulty falling asleep tend to be individuals who have either rhythm disturbances, delayed sleep phase syndrome, for example, or restless legs disorder. People who have difficulty staying asleep or waking up a lot tend to be more individuals who have major depression, sleep apnea, or periodic limb movement disorder. Also, if we are to treat conclusively the patient who has difficulty staying asleep, the medications which we would use are going to be different than the person who has difficulty falling asleep. Let's talk a little bit about the techniques to treat insomnia directly, behavioral and pharmacologic techniques. From a behavioral standpoint, we have a host of techniques which have shown to be effective. For example, stimulus control therapy, i.e., if unable to fall asleep within 20 minutes or half an hour, or if you wake up and can't fall asleep within that period of time, get up out of bed, do something else outside of the room, and then come to bed only when you feel sleepy. This diminishes that association between sleeplessness and the bed. Relaxation therapies, for example, biofeedback, progressive muscle relaxation, performed once a week over 12 weeks, has been shown to be very, very helpful. And finally, sleep hygiene education, those habits and behaviors which tend to be sleep disruptive, should really be looked at carefully, such as caffeine consumption close to bedtime, a room that's brightly lit or not dim, I should say, in the afternoon or in the evening hours, or patients who sleep during the course of the day far beyond their intended bedtimes, or nap too much. These behaviors can be mitigated, can be addressed, I should say, and conclusively mitigate insomnia. Now, let's go to the pharmacologic treatment options. Many of these pharmacologic options are already utilized by patients. For example, alcohol, which is not a great sleeping pill, should be avoided because it can actually cause more sleep disruption. But there are many over-the-counter or homeopathic remedies which patients use as well. For example, valerian root. Valerian has been shown to be somewhat effective in some cases. Not a lot of great studies done, but can be productive in some patients' cases, but should be watched out, some of the side effects should be watched out for. For example, hepatotoxicity if administered with a lot of other medications. The first generation histamine 1 antagonists, such as diphenhydramine, can be sometimes effective, but again, they may have some side effects if used at high doses, including the possibility of long-term anticholinergic problems such as urinary retention, constipation, but also maybe even production of dementia. The melatonin, used very commonly. Melatonin is a modestly effective drug, may reduce sleep latency by a few minutes, may increase total sleep time by a few minutes. It isn't dependably effective in meta-analyses. I would say that at low doses, sometimes it tends to work and sometimes it doesn't. I would be very careful about using melatonin for too long of a period of time because it can actually cause problems, possibly along the lines of many other receptors, may diminish fertility, may actually change the responsiveness of chemotherapeutic drugs. So it's not a great agent for long-term usage. And finally, things like St. John's wort, hops, chamomile, these unfortunately, although available, have never been shown to be effective in most cases. Let's go on to the prescription agents. There are some that are FDA not approved for insomnia. For example, antipsychotics, anticonvulsants, quetiapine is commonly used. These agents can be useful in psychotic patients, certainly, by diminishing psychosis and producing better sleep. But my suggestion is to not use them in primary insomniacs. They may have some negative effects. Of course, we all know what they are: metabolic disturbances, tardive dyskinesia, and so on. So reserve those for the psychotic patients. What about the ones that are FDA-approved hypnotics for insomnia? They fall into generally two classes: the ones that are benzodiazepine receptor agonists and the ones that are agonists of different receptors. In terms of the benzodiazepine receptor agonists, the older drugs, such as estazolam, florazepam, temazepam, triazolam, these can be very effective. The reason we don't use those very much anymore is that they have long half-lives and tend to have difficulty in terms of daytime sedation. So used sparingly at low doses, they may be helpful, but I would be careful about daytime sedation. The ones that are probably a bit more, a bit safer in this regard are the so-called Z drugs, which are the selective benzodiazepine receptor agonists, things like zaleplon, zolpidem extended release, S-zopiclone. The last two agents, zolpidem extended release and S-zopiclone, also called Ambien CR and Lunesta, are good drugs in terms of panacea approaches for the entire night. They can produce improved sleep latency and help patients wake up less. So they're good for the beginning of the night, the middle, and the end of the night. Things like zaleplon, pure zaleplon or Ambien, Sonata, zolpidem, which is Ambien, are effective for the beginning portions of the night, can produce improved sleep latency, but generally are not effective for the middle to last portions of the night. All of these drugs, of course, are DEA scheduled, and we should be watchful for that from that standpoint. The newer drugs, which are not benzodiazepine receptor agonists, are also helpful. Ramelteon, also called Rosarum, is effective for the beginning portion of the night only. That's a melatonin receptor agonist. It exists in one dosage form, 8 milligrams. Doxepin low dose, 3 to 6 milligrams, is effective for the middle to the late portions of the night. So it's a good maintenance drug. Interestingly also, both Ramelteon and Doxepin are not scheduled, so they may be helpful and safe for patients who have drug addiction histories. And finally, orexin receptor antagonist, suvorexant. Orexins are neurotransmitters which control other neurotransmitters, and the reduction in their tone tends to be helpful for sleep. Suvorexant is the only drug available currently, and that drug affects both sleep initiation and maintenance. And soon, we think, will be another drug introduced in this category called lemborexant, which is also an orexin receptor antagonist. So in general, we think these drugs are effective. They have safety profiles. We should be careful, of course, about some of the newer caveats with the benzodiazepine receptor agonists, especially the Z drugs. If mixed with alcohol and other sedatives, they may cause some amnestic behaviors, such as sleepwalking, doing unusual things in one's sleep. And the FDA recently has issued a warning that if patients have these types of parasomnias when using the Z drugs, they should never be re-challenged with those Z drugs. We also should be careful about using these drugs over long periods of time. Although they can be effective in chronic usage settings, we should reevaluate the patient every few months to make sure that they're using the lowest effective dosage. So in summary, insomnia is a chronic condition in many cases, tends to be fairly common in psychiatric populations. Our first approach is to treat the comorbidities as best we can, and direct treatment of insomnia is a rational choice, both with behavioral and pharmacologic techniques. Looking at the insomnia pattern over the course of the night, whether it's an initiation insomnia or maintenance insomnia, can be very helpful for us in terms of choosing the right pharmacologic agent.
And that's a wrap on episode 81 of the Psychcast by MD Edge. Let's get to this week's credits. Our masterclass lecturer this week was Dr. Karl Doghramji. Psychcast audio producers are Gina Henderson and Jeff Bauer. MD Edge podcast producers are Editor-in-Chief Mary Jo Dales, Executive Editors Denise Fulton and Kathy Scarbeck, MD Edge Multimedia Editor Terry Rudd, and our social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MD Edge Podcasts, Nick Andrews. Thanks for joining us for episode 81 of the Psychcast by MD Edge.